Good afternoon, everyone. This is Cheryl Larson with the Midwest Business Group on Health, and welcome to this afternoon's webinar, The Pros and Cons of Copay Accumulator Adjuster Programs and Drug Copay Cards. And we're going to be focusing on the impact of these two programs sort of colliding on people in high deductible health plans. We're excited to have a robust group of speakers and a big group of people who are participating in the program. A couple of housekeeping details. All questions should be submitted through the chat function or the participant feedback function. My colleague Judy Hearn will be managing that. We do have two sections where we will have questions open to the audience, but you can feel free to submit questions at any time during the webinar, and we will do our best to get to as many as we can. We have a pretty tight agenda, and we did not send out an agenda, formal agenda, so I will be introducing each speaker and not going into a lot of detail about their background, but let me just share that all of the people on today's webinar are colleagues and friends and members of MBGH who have been actively involved in talking to us about this challenging topic for a long time, and we've got data to share with you today. We've got stories, we've got research, so I'm going to go ahead and get started. Just a little bit of a background on the Midwest Business Group on Health. We have 125 members. The majority of those are large and mid-sized and jumbo employers, the health benefits and human resources professionals from those organizations. These folks are spending a lot of money on healthcare annually, and we represent about 4 million covered lives. As a 501c3, our focus is on education, networking, and benchmarking, and we also do a number of health benefits research projects. We have employer toolkits, and I'll share a little bit about those in a minute. And then we are involved in a number of community-based initiatives, and we have a small purchasing arm. I wanted to share what we have coming up in 2019. We are pretty excited to have our calendar pretty full already. In January, for the employers on the phone, we have an employer-only forum where we're going to focus on wellness, well-being, and engagement. We are having an on-site program on February 12th on marijuana legalization and how this is impacting states across the country, but we will be talking mostly about the Midwest, but examples of what other states and employers across the country are doing. And then on February 20th, we're working with the University of Illinois Chicago to conduct a program on healthy aging employer strategies. So not only those of us that have an older workforce, because certainly people are working longer, but also those of us that cover our retiree population. In March, we'll do a program that is going to cover some hot trending topics, so oncology management, integrative pain management, and kind of a tie-in to that is the opioid abuse and misuse problem, and then high cost for the employer community, musculoskeletal. In April and August and December, we will do employer-only roundtables, and the theme of those will be released later. In June, we always have our employer forum on pharmacy benefits and specialty drugs, and I suspect we'll be talking about this again then as we did in June of this year. September, we have our annual member meeting, and then we also are collaborating with the National Association of Worksite Health Centers that will focus on a program about employers and on-site clinics. And of course, in May, on the 8th and 9th of this year, we'll have our 39th annual conference where we are focusing again on the key topics of trust and accountability in healthcare, transparency, employer initiatives across the country to focus on managing benefits, managing healthcare costs, managing the health and well-being of employees and family members. And we're excited on May 8th, Dr. Michael Roizen of the Cleveland Clinic will be our keynote. Other speakers will be announced in the month of January. Just a couple reminders again that you will all be placed on mute during the webinar so that we're not hearing any of you. Our speakers obviously will not be placed on mute. And again, a reminder to submit questions using the chat function. So this has been one of the most challenging programs I can recall in my 20-plus years of being with the Midwest Business Group on Health, because there are two very different schools of thought from different stakeholders in the marketplace about copay cards and accumulator programs. And so what I'm going to try to do in the next few minutes is provide a baseline of this, where we're at in these two places, do some explaining to you on where we see these programs, and then we'll have Dr. Bruce Sherman, who is a medical director with the National Alliance of Healthcare Purchaser Coalitions, talk about some of the drug affordability issues for people in high deductible health plans and low-wage workers. Following Dr. Sherman, we'll have a stakeholder panel, and then following that stakeholder panel, we'll have the employer perspective. So let's start by talking about where copay cards came from. I think the majority of us are familiar with them. They are offered by pharmaceutical manufacturers to cover a patient's cost share for certain specialty drugs as a way to make them more affordable. And I bring, since today's program focuses less on traditional drugs, we're going to be talking in the context of specialty drugs. Now, proponents of copay cards view them as promoting affordability and access to specialty medications, and they often view accumulator adjuster programs as a way to create cost barriers to specialty drugs. In terms of accumulator adjuster programs, these are offered by PBMs as a counter solution to prevent copay cards from counting towards a patient's deductible and out-of-pocket costs. And proponents view copay cards as a way to encourage unnecessary use of higher-priced branded drugs and as a way to undermine an employer's intended. Our next slide. So we wanted to provide, these are general statements that we're making. We wanted to provide a fair and balanced overview of both copay cards and copay accumulator adjuster programs. And this is based on the research that we did and the speakers that we've got. There's much, much more that we could talk about, but we tried to distill it into smaller bites. So what do we know in terms of pros about copay cards? They're helping people get medications at a lower cost. They do count towards the patient's deductible and out-of-pocket costs if that employer is not using an accumulator program. You'll notice that once the copay card limit is reached, insurance kicks in. And by this time, we know that most patients have met their out-of-pocket max, and that eliminates their cost share. We also see copay cards as a pro in terms of removing financial barriers that prevent people from being more adherent to treatment. And we'll hear a lot more about the research related to that from Dr. Sherman. Some of the cons in terms of copay cards is that they're not usually tied to income. So the copay card is available to the patient whether they need financial support or not, for especially commercial plans. Copay cards also are seen as bypassing existing plan design efforts that were initially created by the employer, and they can also insulate patients from the real cost of drugs by promoting use of higher cost drugs at times. There is also concern that use of copay cards increases the overall cost of drugs. Now we're going to talk a little about the pros and cons of copay accumulator adjuster programs. In these programs, the pros are we get to track a patient's true out-of-pocket costs, making sure that both the patient and the employer are contributing to the benefit plan design as the plan was designed. PBMs and plan sponsors can also use these copay card values to bring down costs for the plan. This program ensures that members have equality in the benefits offered, as each member pays the same premium and has the same coverage. So an example of that inequity or inequality in a plan design is the example of two patients I'll share. One patient, let's say, has access to a drug copay card to satisfy their out-of-pocket costs, while the other incurs costs for medical treatment or services, but the patient doesn't have access to a copay card or any financial support, so they pay the entire amount. Many employers believe that this causes inequity in plan design, so maybe we'll touch on that in a little bit. Some of the cons regarding accumulator adjuster programs is that once the copay card is exhausted, and this usually occurs by the third or fourth month, the patient is responsible for all costs until they satisfy their out-of-pocket. This as a result is shifting more cost to the patient and certainly can result in non-adherence and or higher use of healthcare services. So I just wanted to share, this is from an AbbVie resource titled, It's Not the What, It's the How, that looks at high deductible health plan benefit designs for members on specialty medications. And it's a fictional scenario for a woman named Jane who's using her copay card for a specialty drug. Her employer is using an accumulator adjuster program that's offered through the PBM. The manufacturer copay card maximum of support is $12,000. We'll see that in the bottom right. The cost of Jane's medication is about $4,000 per month. So for the first 3 months of the year, she pays an out-of-pocket of $5 per month, and then the manufacturer copay card covers the remainder at a little less than $4,000. Because accumulator adjuster programs typically don't allow the copay card support to count towards Jane's deductible, by the 4th month, or in this case April, she's surprised that she owes about $3,900, $3,955, and she's going to need to continue to pay that until she reaches her maximum out-of-pocket. Right now, and you'll see on the bottom left, in the case of someone in an ACA plan, that out-of-pocket deductible is $7,300. So this is a real quick example of what we're seeing in the market and what can happen to people. This slide, and I guess we can't see the top. Can you scroll that up, Judy? Maybe it won't do it. But that's okay. This is from Kaiser, and I was just sharing it so that we could get a sense of around 2000 through 2018, what kind of plans employers are in. So I actually might have this slide. It's essentially telling us what types of plans employers are in, and we have to remember Kaiser's data is usually less than 200 employees. In their case, in an ACA environment, a large employer is someone over 200 employees. Look at the far right, starting with 2006, and you can see how the use of high deductible health plans has increased. It was pretty slow until about 2011, 2010, and now today we're seeing that 29% of these smaller employers are utilizing high deductible health plans. Next slide. This is more realistic to MBGH members today. This is a National Business Group on Health survey that came out last month that shares a couple things. Right now, we're seeing that 30% of their membership, which is, as you may know, primarily, this was 170 large employers that represented about 19 million lives. This was conducted in the months of May and June of this year. 30% plan to offer a high deductible or CDHP as their only option in 2019 and beyond. What's interesting, and I have several theories behind this, the number of those planning to offer them or that did offer them as their only option was 39% in 2017. Now, I think part of the reason is they're recognizing some of the cost barriers that these plans are having, but I know that we're going to be talking about this with our panel today, and I don't want to share too much about the reasons behind that. 17% of the respondents of the survey are currently using accumulator adjuster programs, and one of the consultants working on this initiative expected that to be at 20% at year-end 2018, and we're there right now. And then finally, 56% are considering these plans by 2019, 2020. So they've been around for a bit, not real long, but they have had considerable growth in recent years. By the way, everyone's going to get a copy of these slides and an evaluation form after the program, so you'll be able to look at this other chart. I don't want to go into too much detail. I thought this was really interesting. This was from a PBMI, their 7th annual Trends in Specialty Drug report that was 2018. This is 3 different scenarios. So the guy on the left is saying that our out-of-pocket costs are low, but we still don't think it's fair that the company has to cover drugs at 100% when the actual out-of-pocket cost has not been met. It's not fair to the employees that are paying the full copay amount and had to hit the annual max just because they don't have a copay card. In the middle, we've got someone else sharing, it's wrong and I believe it is a fiduciary lapse on the part of the PBM to apply money to the plan participant's deductible, copay, and coinsurance using some other source of money. And then finally, you've got another employer who said, for specialty drugs, it's giving the member access to otherwise high-cost medications at little or no cost that may keep that person from seeking medication at a hospital or from being hospital for not being treated appropriately. I want to bring us back. I'm not going to go into a lot of detail, but that middle section talking about fiduciary is very important. We're not going to go into a lot on what's going on in this space from a legal perspective, but it is really, really important to make sure that you've talked to your consultants and other groups about the fiduciary responsibility from an employer, not just from this perspective, but from a much broader perspective as it relates to other areas in the industry. Next slide. So I am pleased to introduce our speaker. Bruce, are you with us?
I am indeed.
Wonderful. Bruce is a really good friend and colleague, and I was so appreciative for his willingness to come and share the research that he's done in this area. Again, this webinar is about use of copay cards and the collision with high deductible health plans, but in the end, what we're seeing in the marketplace is the impact for people in high deductible health plans because they have become so prominent. And so welcome, Bruce, and we look forward to hearing about what your research shares with us.
Great. Thanks, Cheryl. And good afternoon to everybody. I wanted to take the next 20 minutes or so to talk about this issue. We were particularly concerned within a population as to what the impact of the Copay Accumulator program was, or Copay Accumulator adjustment program was on patient compliance with medication. So that's ultimately what I'll talk about, but I want to set the stage with a few slides first. If we can go to the next slide. What I think is important to point out, and we'll address this a little bit later, is the issue of prevalence of chronic conditions. As you can see now, the numbers have only been increasing in recent years. 59% of people with a chronic condition. The important thing to note here is that the prevalence of conditions requiring treatment with a specialty pharmaceutical agent is probably in the 1 to 2%, which is comprised mostly of individuals with autoimmune disorders and also HIV. The issue here is that those individuals experience a disproportionate cost of treatment relative to the nature of their medications. If we go to the next slide, it's not simply a matter of the medical and pharmacy costs, but also the so-called indirect or other costs that employers may experience as a result of individuals with chronic conditions, particularly those that are suboptimally treated. You can appreciate that the medical costs are literally the tip of the iceberg relative to other associated organizational expenditures. And as we transition to the next slide, because, as Cheryl has acknowledged, because healthcare costs have been increasing, this transition to high deductible health plans began probably a good 10 or so years ago, and we've certainly seen the number of HCHP enrollees increasing over time. About 30% of individuals in receiving commercial insurance are enrolled in high deductible health plans. The problem, and I'll share a couple of those with you on the next slide, the problem is that many of these individuals don't fully understand what they're getting themselves into with a high deductible health plan. And as you can see from the data presented here, we know that the number of individuals that really understand their benefits design is nowhere near what we would expect it to be. It's easy to understand why premiums and deductible numbers are higher because people have car insurance and they get the premium and the deductible. But it's also for that reason easy to understand why the out-of-pocket maximum and co-insurance are lower. On a humorous note, it's interesting to appreciate that when one thinks about the proportion of the workforce in the U.S. that is involved in healthcare, it's kind of an intriguing coincidence that that number is 9%. And that's the same percentage that could identify these four insurance terms. If we look at the next slide, further confounding the issue is one of affordability and cost and income. And what we note here is that there is a substantial portion of the population that does not contribute meaningfully or to a significant degree to their HSA plan. And that results in these individuals not having money set aside to pay for their healthcare expenditures. On the next slide, we see the implication, or perhaps even another manifestation of comparatively low income, individuals living in households where income is less than the national median may be living paycheck to paycheck, as we see here, and as a result may be challenged to contribute to an HSA and use that health plan in the way that it was intended by their employer. Moving on to the next slide, we see the implications or the consequences of these issues with both health literacy as well as financial limitations or affordability concerns with respect to health care. And you can see that a number of a good proportion of individuals are not optimally compliant with recommended care. Many of you may have seen a recent study looking at diabetes because of the cost of insulin. There was a study that came out in the last week highlighting the fact that individuals were rationing doses in order to be able to, or as a result of limited finances. So if we go to the next slide, and I think Cheryl highlighted these points already, questions and concerns about what employers say about the copay assistance cards and whether they are fair. If we go to the next slide, we see a consequence of what some of those employers are doing, and this was published in Reuters just last month. And the irony that I see here is in that first sentence that describes punishing drug makers for using discount cards. Our major concern is not punishing the drug makers. Our major concern is whether patients can afford to get the medications that they may need to meaningfully treat their symptoms. So we were concerned about the idea of copay accumulator adjustment programs being implemented, and did a study looking at data from WriteOpt, which is if we go to the next slide, which is a private exchange or a bundled portfolio offering of benefits programs. We looked at 150,000 individuals from this group of 15 employers where a copay accumulator adjustment program was put in place. we looked specifically at a year-long period prior to Copay Accumulator Adjustment Program being implemented and for the 10 months after the Copay Accumulator Adjustment Program being operationalized to see what kind of impact this program had on patient adherence to medications. And I'm going to show you the results of that in the next few slides. So we can go to the next slide, and I think we may just skip that for the sake of time. Go to the next slide, and I'll show you some of the actual findings. And graphically, what you can see here is that prior to the implementation of the Copay Accumulator Adjustment Program, the medication adherence as measured by so-called proportion of days covered, meaning that the proportion of days that individuals had prescriptions on hand, the lines over this period of time starting from the beginning of 2016 going forward, the lines are reasonably parallel. But when we look at what happened in 2017 after the Copay Accumulator Adjustment Program went in place, we see the PPO, individuals in the PPO plan maintaining their medication adherence where the HSA enrollees are dropping off. Look at the next slide. What this translates to is that over time, we saw about a 30%, almost a 30% discontinuation rate during that 10-month period of individuals with autoimmune disorders enrolled in HSA plans relative to individuals with autoimmune disorders enrolled in PPO plans. So this 4 times greater discontinuation rate
Bruce, we're having trouble
the
hearing you.
enrollees.
Bruce, can you hear me? It's Cheryl.
Yes, I can.
Do you have noise behind you?
No, I don't.
Okay, well,
You're
then
somewhere
could
else.
all of you check to make sure that your phones are on mute?
Much better.
Thank you, much better. Thank you. Bruce, could you go back to the beginning of the slide, please? Thank you.
Sure. So what this slide shows for those that couldn't hear, individuals that are enrolled in HSA plans with autoimmune disorders had almost a 30% discontinuation rate in the 10 months during which they were subject to the Copay Accumulator Adjuster Program. In contrast, individuals in the PPO plan with autoimmune disorders had only a 7% discontinuation rate, so a 4-fold greater discontinuation rate among the individuals in the HSA plan. When we look at the next slide, you can see, get a greater sense of the significance of this. You're seeing those same numbers on the left-hand part of the slide here for the absolute discontinuation rate. In order to determine whether this was really a finding of significance, we looked at patients who were receiving medications for treatment of multiple sclerosis. This drug, interestingly, or these drugs, were on the preventive drug list. So no deductible to be reached. And what you notice is that there is really no statistically significant difference between the two groups of patients on the right-hand side of the graph, the people that were in the PPO plan and the people that were in the HSA plan. So contrast that with the slide on the 2 bars on the left-hand side where you see that significant magnitude of difference. Now, what does discontinuation mean to patients who are potentially not taking their medications because of cost? We'll get to that in just a second, but I want to show you the next slide. And bear in mind that our research was done on a broad population of individuals without respect to analysis of different wage bands. This was pharmacy-only data that we looked at. This is an earlier study that we had performed looking at the association of healthcare use by wage band. The line across the top of the graph shows the relationship of medication adherence by wage band, and what you notice is a significant drop in medication adherence among low-wage workers. We presume this to be an affordability concern. So when we think about our data in this study, we have major concerns that this is disproportionately impacting low-wage workers, although we don't have that evidence yet. Let's go to the next slide. And I want to provide some evidence, and we certainly have data just like this for people on small molecule or non-specialty drugs. But what this shows is in a modeled analysis of these four conditions as shown on the bottom of the chart, a 10% increase in medication adherence for specialty drugs was associated with a net reduction in medical costs. So what this means is that it is very likely, based on this modeling, that if people decrease their adherence to specialty drug medications, that their overall healthcare costs are going to increase. In other words, the opposite of what we're seeing here, where the authors modeled an increase in adherence associated with a reduction in healthcare costs. We are postulating that this reduction in medication adherence could lead to less well-controlled disease that would result in a greater prevalence of provider visits, potentially emergency department visits, hospitalizations, the net result being an increase in overall healthcare expenditures. So the other point to make here, and haven't had a chance to make this, and I'll do it quickly in the interest of time, so when we look at the number of people that are taking these drugs, which is, again, roughly 1 to 2% of the population, if the difference in costs associated with a drop in medication adherence that we saw in the study for HSA enrollees was spread out across the broad population. In other words, if the Copay Accumulator Adjuster program wasn't there, we've modeled this, and it looks like it's about a penny per member per month additional cost to the employer to cover these additional drug costs. So while we may be substantially negatively impacting the health of individuals that have to discontinue these medications because of cost concerns, the overall employer cost of addressing that need it is quite small by comparison to overall expenditures. So let me wrap up with one additional slide, and that is just some study conclusions. I think I've shared with you already. We saw the high deductible enrollees on autoimmune drugs had a greater risk of discontinuation and a lower proportion of days covered and fill rates, that the preventive drug list seemed to protect individuals from the impact of the Copay Accumulator Adjustment Program and the reduction in medication adherence. And while we looked only at pharmacy data, we certainly are interested in looking to see what is the clinical impact, what's the healthcare cost impact of this treatment discontinuation among patients that had to stop their medications because of the additional expense generated by the Copay Accumulator Adjustment programs. So we're concerned, as I have expressed, that maybe these financial barriers are having a negative impact on patient adherence and on clinical status, particularly among low-wage workers, And if we can think about ways of more thoughtfully designing benefits to minimize this adherence concern, maybe everybody wins. And if we look at I think there's one more slide here. Just think about this as a sort of a theoretical or an ideal vision. If we focus on the goals of the employer and the goals for the employee of improved treatment compliance for the employee, for the employer, decreased medical spend, and improved business performance, maybe there is a way to more meaningfully align goals. And hopefully we'll talk about that later in the presentation. Cheryl, I'll turn it back over to you.
Great, Bruce. Thank you so much. We do have one question, so I'm hoping you can answer this. In terms of the discontinuation rate we saw, do some patients discontinue and then switch to alternative lower-cost drugs that treat the same condition?
You know, it's a fabulous question. What we looked for was we didn't look specifically at that. That is something that we very much want to do. What we did look at was to see whether individuals might switch from one medication in the same class to another medication in the same class to essentially refresh that copay card. And we really didn't see much of that, which was, frankly, a bit of a surprise to us.
Very helpful. Well, thank you very much, Bruce. We'll be talking to you again in a few minutes. Our next presenter is part of a stakeholder panel. I'll introduce each speaker as we move forward. And so if you'll switch slides. We are now going to hear from Robin Kahn, who is the Associate Director of Employer Marketing for AbbVie. Welcome, Robin.
Thanks, Cheryl. I think for me, the subject of Copay Accumulator adjuster programs goes beyond my work in the biopharmaceutical industry, obviously. We have a stake in the game, but Copay Accumulators for me have unfortunately become personal. And I want to share a HIPAA-compliant story with all of you. I attended my high school reunion last month. I'm definitely not going to share what year that reunion was for, but ran into a friend of mine who I hadn't seen in a really long time. And he and I were catching up on life, families, work, what have you. You know, he's got a good job with the city, married, 2 girls that are now in high school, same high school we actually attended. And when I shared with him that I worked for AbbVie, he says, oh, I'm on Humira, or at least I used to be for my Crohn's disease till my copay card ran out. And so I was pretty sure I knew what might have happened to him, so I asked him to tell me more. I asked him what were his health plan options, what decisions did he make, did he and his family put the right financial planning in place. I wondered if he had actually made the right choices and did he understand his insurance or not. Bruce mentioned earlier that 9% of people really understand some of the basic insurance terms, and it turns out that my friend is actually one of the 9%. He shared that when his employer offered a high deductible health plan with an HSA this year, he sat down to do the math. He knew he was going to have a pretty large deductible with his family coverage. So he took all of his premium savings and put that money into his HSA each pay period. He shared that several years ago he had had surgery for his Crohn's and the bills were pretty large, but that the hospital allowed him to pay them back with an installment plan. So he figured if he incurred a big expense again this year, that he'd just be able to pay it off with his HSA as that account grew over the course of the year. He tells me that his specialty pharmacy called him in January to refill his Humira, and it was going to cost him $4,000, which is the amount of his family deductible. But because he only had a few $100s in his HSA, he asked the pharmacist if he could pay that $4,000 over time. But they said no, that he had to pay all of it before they would ship his drug. He said, I'm going to have to call you back, and then went online to Google what his options might be. And he found that Humira offered a copay card, which he then used to help him pay for that prescription in January. The pharmacist asked if he'd like to put that copay card on file for his subsequent fills, which he did. And he thought he was going to be all set for the rest of the year. But the bigger surprise for him came when that specialty pharmacy called him back a few months later to tell him that his copay card ran out and that it was going to be probably about $3,000 for his medication. I remember him telling me he was confused, he was frustrated, he had no idea what had happened. He thought he had done all the homework he was supposed to do to pick the right plan. Now, by this time, he maybe had about $1,000 in his HSA, but that's still not enough to cover the $3,000. I asked him, well, don't you have a credit card or savings that you could use? And he said, no, all of our savings goes into the 529 plans for our daughters, and we don't have extra savings, and I certainly don't have enough balance on a credit card to pay. On the flip side, though, he made too much money to qualify for free medication. So unfortunately, he had no choice but to stop taking his medication. And this is what's happening to patients that are subject to these accumulator adjuster programs. These are your employees and their family members. And for the 2% who need specialty medications, almost all of which maybe have tried and failed the lesser expensive therapies, we have a healthcare system that allows people to finance their medical care, but they can't finance their pharmacy care. So I wanted people to think about that in the context of how these programs work. And I also then want to thank you, and I'll turn it back over for our next speaker.
Thank you, Robin. Our next speaker is Colette, who is the Senior Director of Payer Relations. Colette is with the National Hemophilia Foundation. Colette, I want to say it's Koulianos. Is that correct or close? Colette, are you on the line? Colette, unmute yourself if there's a chance that you're muted. One more try. Colette, are you with us? Maybe you don't know that I might have butchered your name. Okay, so we're going to try to unmute you and see if unmute everyone and see if that helps. We show that you are on the call. So what I'd like to do, Lauren, are you with us? Lauren Bella? Hold on, I need to unmute her. We're going to unmute you in just a second.
The conference has been unmuted.
Hello.
Colette, is that you?
Yes, it is. I keep trying to talk. I'm not muted, but
I'm so sorry. It's really, really hard to hear you. But I do ask, since I believe everybody has been unmuted, that if there's any background noise in where you are to all of the participants, that you please put the phone on mute if you can still hear us. We would greatly appreciate that. And Colette, you're probably going to have to talk pretty loudly so that we can hear you. But welcome, sorry about that, and let's get started.
Hello, this is Colette Koulianos. You said it perfectly. I'm still hearing background noise on phones, but hopefully
we're going to try and mute everybody, but not you. That we're working on that right now. So just hang in there and keep going.
Okay. So you can go ahead and advance for me, please. I am the Senior Director of Payer Relations for the National Hemophilia Foundation and have been passionately working on this issue since we learned about it in December of 2016. So I'm going to review just some facts about the Accumulator Adjuster Program with specific to healthcare coverage. We know that these Accumulator Adjuster programs target high deductible health plans and really have the biggest impact on patients that are in a high deductible health plan. 43% of individuals with private insurance are on a high deductible health plan. We know in 2017, greater than 1/3 of employers offered high deductible health plans only. And the IRS minimum deductible to qualify as a high deductible health plan is $1,350. Now, this information is important because my next slide will explain why. So the average deductible for employer-sponsored health plans as of Kaiser's last report was $1,500. And the maximum out-of-pocket as required by ACA is $7,350 this year for an individual, $14,700 for family. Okay, now that doesn't include the premiums, as we all know. So if you would go ahead and advance. So we'll talk about the cost burden to Americans and the average median household income. And I don't know how those last two numbers got on there. This isn't a case of decimal points going out. It's supposed to be 61,372. So my apologies. But that's the average median household income, all right? And so half of all Americans have nothing put away for retirement. You'll see my sources are cited down at the bottom of the slide. 35% of Americans have less than $1,000 in savings. 34% of Americans have no savings at all. And 63% of Americans don't have enough money to cover a $500 emergency, all right? So if you think about this in terms of the high deductible health plans and what position being left without having the support to help get their medicines, you'll see where I'm going with this. But go ahead, please. Next slide. So health insurers have been, implementing strategies for some time, value-based strategies, increasingly aimed at encouraging patients to move away from higher cost settings from hospitals, instead using lower priced outpatient providers or in-home services to reduce the healthcare cost and to hold down the premiums. Many insurers require prior authorization for services done at hospitals for administration of intravenous drugs, which, by the way, hemophilia patients do require intravenous infusions that they self-infuse. They're taught from an early age. In fact, we work with populations from 7 years old and up to self-infuse at home for better quality of life, but it also lowers the overall cost of care. And so we know that insurers have been using these tactics for some time and continue to drive in that direction to incentivize patients not to use the highest cost setting. In Michigan, Blue Cross Blue Shield of Michigan and Priority Health teamed up and created a program that eliminates coverage for home infusion services at a hospital or outpatient centers owned by the hospitals, projecting a 50% savings and greater if that patient was self-infusing. So I bring this up because this is working actually counterintuitively to other strategies that employers have been putting in place to try to lower healthcare spend. So if you would please, next slide. So I'm going to give this is just one example, but we have many, many examples across the country of patients that have been affected by these copay accumulator adjuster programs. And I want to preface right here with saying that I know when Dr. Sherman gave his talk and we talked about whether he looked at if a patient was non-adherent, did they eventually come back on to a lower cost, cheaper option? For hemophilia, there are no generics. For hemophilia, there are no biosimilar equivalents. So there are no lower cost options. So I want you to keep that in mind. But this father, we'll call him John Doe to make sure we're HIPAA compliant, has 2 sons with severe hemophilia. He's an employer-sponsored high-deductible health plan with an accumulator adjuster program. By the way, his employer only offers high-deductible health plans. His salary is $35,000. He has a deductible of $3,000 times both boys. Obviously, that's $6,000. His max out-of-pocket for both boys is $14,700. That's nearly half his salary. The monthly drug cost for his sons is approximately $14,583. So if you multiply that by 2, you're looking at a monthly drug cost of almost his salary, $29,166. Go ahead. All right. So what happened when he used up his copay card for each of his sons, which for in this particular case ran out 3 months into the year, then he was no longer able to get the medication because there were no options that worked for him. So he could no longer treat his sons prophylactically, which is being proactive, preventing bleeds from occurring, which is when it becomes really costly for a hemophilia patient. And his only option was every time the boys had a bleed was to take them to the emergency room for emergency room infusions. And just for a bit of background information, the annual bleed rate for folks that are non-adherent results in an average of 37 annual bleeds versus 1 with adherence. Now, each bleed would need multiple infusions to treat, major dose infusions, by the way, which is a double dose, sometimes multiple in a day. And so that would require multiple visits to a hospital to treat. And the total cost of care in a hospital setting versus self-infusing at home is significantly more costly, which each of you, I'm sure, know based on your data. And it reverses any alternate value-based strategies you may put in place to try to incentivize the patient to stay out of the hospital. This works counterintuitive to that strategy. And it's a life and death risk. For hemophilia patients specifically, if they have a head bleed, if it's a little kiddo and he falls and hits his head, or it's a major organ bleed, they must infuse within an hour. And I probably don't have to say that most emergency rooms, nothing happens in an hour, and that's from the moment of injury. So it's really, for hemophilia patients, this is a life and death scenario. If you would please advance the slides. So at the end of the day, I will end with these comments, that the National Hemophilia Foundation has taken the lead in working with payers and providers to drive value-based solutions that can and do drive savings. We've been instrumental with many of the largest payers in the country and many employers and employer coalitions in driving these saving strategies since 2014 when the work started. And this is not one of those strategies that's going to work, especially for patients like hemophilia patients that have no generic alternative, that require high-value drugs, and that it's a life and death scenario. So these programs don't result in the desired outcomes. And so that's, I guess for us, the key point that we want to make sure that you consider, not trying to make this a one-size-fits-all approach. You would please, I think that's the end of my slides, but.
Thank you, Colette. That was great.
Yep.
All right,
Thank you.
wonderful. And our final speaker on this stakeholder panel is Lauren Bella. Lauren is the Senior Director of Member Value at Sister Coalition Pacific Business Group on Health. And I'm not even gonna give any overview, Lauren, of the role that you're playing. I'm excited to hear, you know, kind of your perspective from the employer side. Lauren?
Yeah, thanks, Cheryl. Thanks so much for inviting me to share some thinking with the group. And also, of course, to Bruce and Robin and Colette for sharing their perspectives. I think that the take-home message, which was so articulately given by Bruce and Robin and Colette, is that it is critically important that we don't have benefit designs in place that cause harm to our members. I mean, that's, at the end of the day, I think the points made represent that it can actually cost us more in the long run and cause great harm to our members if they cannot afford their drugs. So I did want to share the perspective. Well, we can go on to the next slide. And the next slide, that's just who we are. Okay, so this is a really, really busy slide, but I made it because, you know, at PBGH and at MBGH and other coalitions across the country, we think about the healthcare system. And we think about our job is often to create change in the system so that we have a better, more value-based system. And we appreciate that we're working with benefit managers whose job it is to create a benefit design that is in alignment with their culture, that fits with their budgetary needs, and that you know, attracts good employees. And so we mesh all that together, and what we have is sometimes a system where we find what I call Band-Aids on Band-Aids and Band-Aids. And I think that number one, copay cards, and number two, copay accumulator programs are just yet more Band-Aids on top of the Band-Aids. And let's just walk through this quickly as an illustration. So on the top left, I mean, here's the bottom line. Here's what we have. We've got high-cost drugs, high-cost healthcare, high-cost everything. Okay, well, that's really the problem I would love us to all be working together to address. Band-Aid applied, high cost sharing. Employers have just, they hit the max. They're cost sharing with their employees for two reasons. One is to shift costs and to share costs, and the other reason is to promote consumerism. And you know, on one hand, that's been a disaster. On the other hand, that has worked. We're having conversations in this country that we never had, and we're having those conversations because consumers are having to pay more. The bad news is consumers are having to pay more and sometimes can't afford to. That's the bad news. The good news is we're having conversations we didn't have before. So So the consequence of that, we have low adherence to drugs in some cases because people cannot afford their drugs. Band-Aid, copay cards. Okay, well, that causes a couple of things. One, we see copay cards sometimes on drugs that are wasteful and frankly should not be on your formularies. That's a whole other conversation. But if they, so what happens? Manufacturers can create drugs that are potentially wasteful, cost more than they should, put a copay card out there, cost your patients nothing, and whammo, we've got yet another problem that yet needs another Band-Aid. But then we also have drugs that are high value too with copay cards. And so how do we differentiate between the high value and the low value? And sometimes we get one size Band-Aid doesn't fit all. But we also, these copay cards, keep in mind that when manufacturers are creating copay cards, on one hand it's very, very good because they're helping folks who maybe couldn't afford their drugs. On the other hand, we plan sponsors are paying for those on the back end. I mean, we're not naive to think that there's not a bill in there somewhere for us, and it does insulate our members from the cost of the drugs. Again, it's the good news and the bad news. For some, it's very, very good. For some who cannot afford a very high-value drug, thank goodness there are copay cards. But for others who have a benefit design that is put in place responsibly based on this person's income and ability to participate in this benefit design and taking advantage of the tax advantages of a high-deductible health plan, it's a bad thing because they're getting the advantage of cost-free health care, which was not the intent of the employer. So how do we balance all that? Well, what the PBMs came along and said, okay, we need another Band-Aid. We've got this situation now where we've got all kinds of people not paying their cost share. Yet another Band-Aid is applied. Let's apply this Copay Accumulator program Band-Aid. Well, what happens? We've got really unhappy patients, especially to use Robin's example, if it wasn't implemented well, such that the person did not know. Robin's friends should have been told. They should have been told immediately, but certainly when they gave that coupon for the first month, they should have been told, this coupon is going to expire in 4 months. You will have this expense. That would have perhaps given that person who works for the city 4 months to gather some resources or to figure things out, but he was never told. So that was the poor implementation of a Copay Accumulator program. And what do we have? We have people who can't afford their drugs. Now, what we know, Bruce's study and other studies before his have shown that high cost equals low adherence. If people cannot afford their drugs, they don't take their drugs. Well, if a benefit design is such that there are people who can't afford their drugs, we're going to have that issue. Copay card undoes that. Copay Accumulator puts your benefit design back in place again. If your benefit design is causing harm to your population, it's important to look for options to reduce that harm. Okay, so get another Band-Aid applied. New program. PBMs are now talking about maximizer programs where it's like, okay, employer, maybe we could do the best of all worlds. Maybe we can allow your employee to opt into this program where they take advantage of the copay coupon, but then that remainder of the coupon that we didn't use because they hit their out-of-pocket max and your insurance kicked in, maybe that part of that program can come back to you, the employer. If you guys haven't heard about this, I encourage you to talk to your PBM about it. But be mindful. It's not totally sure that this is legal. So there are, this is a new idea. This is the newest Band-Aid ever. And I encourage you to talk to your PBM, but I also encourage you to, consider, is this legal? Are there going to be risks involved in doing it? Are there going to be, am I going to allow it to cover my patient's entire cost share, which means I'm going right back to undoing their benefit design again. The good news is plan sponsors potentially could be made whole. The bad news is pharma, they know when they introduce copay coupons into the marketplace, they budget accordingly because that's an expense for them. And so if we all just hop on this and take advantage of this program where the remainder of the copay coupon unused comes back to us, well, then they're going to have to budget accordingly for that. Prices will get go up again. And there'll be another Band-Aid. I mean, I guess the point I'm trying to make is stop the madness. Let's go back to figuring out why costs are so high and work with your local coalitions and others to try to address that, number A. And then B, make sure your benefit design is appropriate for your population so we don't have all these Band-Aids, which I promise you end up costing the system more in the long run. Next slide.
Lauren, 1 minute. Oh, it's a big slide.
Okay, next slide. So, so thank you. So this is a crazy slide. I'm going to spend a lot of time on it. Just wanted to represent that copay coupons and copay accumulator programs, they come in different colors, shapes, sizes, smells, okay? So I want to be mindful of this because I want you to think about, employers on the phone, to think about their population and how this fits with them. So first of all, number one here, we have wasteful drugs, and PBGH is coming out with a report where we're naming some of them, so I'll do it right now. You know, Duexis, Exelon, Auvi-Q. There are drugs that cost way too much. We did a lot of work in the small molecule place, not the specialty space. These drugs cost too much. They should not be on your formulary. Get them off your formulary. But if they are on your formulary, and they are because often your PBM likes them, they're revenue generators for them. But that's changing. That's the good news. There are coupons being available to your folks to get these drugs that end up costing you way, way, way more in the back end. Okay, that should be a no-brainer. Those drugs should not be on your formulary. If your consultant's not talking with you about it, ask Cheryl or I. We can get you in touch with a consultant who knows what they're doing in that space. 2, coupons supporting really high-value specialty drugs. Okay, you want to be mindful of very high-value specialty drugs that are in place, keeping your folks alive, your hemophiliacs, for instance. And by the way, having them be on these drugs is saving you money. You want your hemophiliac to be taking their drugs appropriately. If their cost share is keeping them from being able to afford those drugs, we need to figure something out. So that's when a copay coupon, or I want to go to number 4, a needs-based program. There are many needs-based programs out there. So for folks who qualify, and not everybody who needs it does, I will say, but for folks who qualify, there is a program. You can make these programs available. You can have that resource available so that your folks know where to go when they're having problems affording their really high-value drug. But I also want to be mindful that just because a drug is a specialty drug does not make it high value and does not mean your folks really need to be on it. Make sure that you are working with clinical consultants who are really astutely monitoring the drug usage. Because, again, somebody who has all their copays paid for them will be more likely to not question it, and that's never in your best interest or theirs, frankly. So I just wanted to point out these different populations. Yes?
Lauren, we need to wrap up. You all set?
Okay. I'm done. That's it.
Wonderful. Fantastic. So I have one quick question for the panel. We do have an audience question that we can try and get to now or in a bit. But my question is, if we were to go back to only providing financial assistance to those who are in financial need, would this take care of the drug affordability problem that a lot of people are facing? Or are there alternative solutions for employers? And I'm asking each speaker to limit their answer to 30 seconds. Robin, do you want to start?
The conference has been unmuted.
Okay, so we're going to be unmuted. So, Robin, I'm going to ask you to start. Or Bruce, do you have a moment? Did you hear the question?
I did, Cheryl. What I'd like to do is wait until the end to address that in context. So I'll come back to it.
Sure. Yeah, I think it kind of does play into where we get to on some of the solutions. I think the challenge comes in oftentimes as a pharmaceutical company. Are we going to start asking patients for all of their financial information before we provide assistance? That becomes very challenging, and I like to think it would be better served at the employer level in the first place as far as wage-based benefit design or other things versus relying on us to be the determinant of who gets what. from a fairness perspective.
Okay, well, we'll couch this question and the one that we have asked to move forward since it's 3:05 to our employees. Yes.
Can I just jump in? This is Colette. I'll have a quick answer. From our perspective at NHF, we're supportive of some sort of needs-based financial assistance program like you mentioned as an alternative. And so that patients who can afford their medication, who don't qualify for that, well, they're just like every other person, myself included, that has to pay for their medication and doesn't get a copay card. But those people who have a high-value drug that have no other way to access it would have that as an avenue. And there are other solutions that I could recommend, but it sounds like we have more at the end opportunity for that.
Yeah, we want to make sure that Bruce has a quick chance to kind of go through some recommendations at the end. And we're going to move into our employer panel, and I'm going to invite Denise Giambalvo, my colleague, the Vice President at MBGH, to kind of run this. So Denise, why don't you go ahead and introduce our speakers?
Oh, thank you, Cheryl. Hello, everyone. So we have 3 people with us today who represent employers. Andrea Lee from Fortune Brands and Home Security. We have Sandra Morris, formerly with P&G, and Lauren Bella with Pacific Business Group on Health. And each of them will introduce themselves and take about 7 minutes to share their experience and perspective on copay cards, accumulate programs with high deductible plans, what we've been talking about for over an hour now because it's such a complicated topic. So I see we have Lauren up on the screen right now.
Actually, no, we're gonna have Andrea start, and then Sandra, and then
go back
Lauren.
to her. Thank you. So, Andrea, if you will kick us off with your thoughts and the journey that you have been on with Fortune Brands, please.
Sure. So there's been a lot of talk. There's been really good conversation.
Yeah.
So over the last couple years, we have looked at our overall benefit plan design, and we do try to take in consideration kind of the overall employee impact, and do understand that the average employee doesn't really understand that healthcare. I mean, I barely understand healthcare and how it works, and I do this for a living, so we constantly are looking at that and from how we design our plans from that lens. And I think over the last few years, we have introduced high deductible health plans, but we have not gone full replacement high deductible health plan, and there's a very good reason for that, is we have always wanted to offer our employees choice, and we want them to make sure that they have opportunities to find the plan that best fits their needs and what they need from health care. So what we offer today are 2 high deductible health plans, very low deductibles, probably closer to the minimum deductible threshold, and then to be considered a high deductible health plan. And then we also offer a standard PPO plan, which what we call is kind of that gold level plan. So we give our employees an option of, based off of what you need from healthcare, these are your 3 plans you can choose from. So we solely believe in providing that choice to our associates. You know, and the reason we provide that choice, obviously another reason is we have, you know, a population of younger generation that doesn't have a lot of healthcare needs, and so they do want that high deductible health plan so that they just use it from, I go and get my preventative care visits, I don't need to worry about, I have it in the event that something happens, but I don't have constant, you know, I don't have a chronic condition I'm trying to manage, or I don't have constant health care needs. So that's the reason why we kind of balanced it. I tried to create balance between all of our plans to make sure that we are trying to address the needs of all of our individual associates. And then, so that's been kind of our journey of the plan designs and where we have fallen into. We don't have any desire to go full replacement high-deductible health plan. We've talked about it over probably the last couple years. I think we've gone back and forth on it, but I think we are very comfortable where we're at unless something catastrophic comes down where we can no longer afford a standard PPO plan, then we might bring that up into a conversation. But I think for right now, we've been very comfortable with that choice option. And so where we've gone, though, over the last few years, obviously, there's a lot of conversation around specialty medication and how do you manage the cost of the rising, how do you manage those costs, and how do you, as an employer, kind of curve that trend a little bit more. We've done a lot of work on the medical plan side to kind of curve that trend. So how can we do that more on the pharmacy side? We tend to be very conservative in our approach. So when I talk about conservative, like we have very little prior authorizations. We don't require a lot of our drugs to have prior authorizations. Now, some people may be like, why? That should be a standard kind of benefit plan design. We do firmly believe in trying, if the drug is the right drug for the member and it's there for their own good and their own health care, then they should be taking it. So like one of the challenges that I challenged our PBM on is Harvoni, for instance, treats hepatitis and it cures hepatitis, but they have it as a prior authorization drug, and that I don't understand why, because if people who have hepatitis and it cures hepatitis, why would we create more barriers? So that's kind of been our general approach on how we take things. We have, now moving on to like kind of the copay accumulators and where we stand, this has been a struggle for me over the last few years, kind of gone back and forth on this, is what I've struggled with is that fiduciary liability piece of, we have members who have very expensive medical treatments and that don't have copay assistance, or they don't have some sort of other financial assistance to offset their cost. So if I'm looking at our entire benefit plan design, I want to make sure that everybody has equal opportunity to what they pay from a healthcare perspective, but also not trying to create these different dynamics where if you're taking this one specific drug and there's a copay card for you, you are allowed to have that offset, financial offset, but this other person isn't allowed to have that financial offset. So it's a very fine line that we walk from a fiduciary standpoint, is how do we manage that? And the other piece of it is when it comes to the high deductible health plan rules, there's no kind of right or wrong answer. And I think we've dabbled with this with our ERISA council around, is it even right? Like they're not even paying for the full cost, and you're pretty much offsetting their deductible, meeting their deductible for them, and then meeting their out-of-pocket maximum for them, and they might have only paid 5% of that total deductible or out-of-pocket. So does that really qualify under the high deductible health plan rules? And there's not a lot of clear kind of guidance around that. And so that's kind of where we struggled with this position for a while on, are we doing the right thing? Is it the right thing from a fiduciary standpoint? Does it create fairness within our plans and what our members pay? And is it right, and does it qualify under the high deductible health plan rules? So we have not implemented them in the past, but we are going to try to implement them going forward in the future. So we're going to put it in 2019 and kind of see what happens. But with that in mind, there was a lot of decisions we made around, okay, what other protections do we have from a healthcare plan standpoint? So the other protections we have is if you don't want to enroll in the high deductible health plan and you want to just go to straight copay, you have the option to enroll in our PPO plan. The other protection is we do seed our HSA accounts, and we do seed them almost half of what the deductible is. So we do feel like we provide a pretty good financial protection with our plans. And our premiums, so our premiums out of pocket from our per paycheck deductions are fairly low for our high deductible health plans. So we purposely keep them low because they're paying more out of pocket, so we don't want them to pay so much from their paychecks for being in that plan. So that was the main reason why we kind of got to where we're at. Now we are going to review it. We're going to see what happens and kind of test it out and see if it does create, kind of some of that care avoidance that a lot of you guys talked about, or non-adherence to medications, and see what happens there. So that's kind of where our journey was and kind of how we got to where we were at today.
That sounds great. Thank you so much, Andrea. And Denise, are you there? I'm going to invite Sandra Morris, who is a principal with About Quality Benefits Design, who as a former employer has looked at all of the challenges and opportunities in this space. Welcome, Sandra.
Thanks, Cheryl. Well, to start out, I just want to say I am personally all about finding ways to help people be compliant to their medication therapy, and I think we've got a long way to go with that. But as a consultant today, I have to, give advice in terms of putting in different kinds of plans, including the high deductible plan. So I approach it, both the pros and the cons of those types of plans, and help to educate employers on some of the things that may be brought to their attention. So from the standpoint of the copay cards, they're helpful. They help people get initiated on their drug therapy, and they're very helpful in maintaining that therapy for as long as it could. But I think where we're losing pace here is making sure that we have educated people that are entering into a high deductible health plan to the point of not just putting out details about the plan, but saying point blank to them, if you enroll in this plan, you need to have this amount of money put aside in a savings account to be used strictly for medical costs that are unexpected costs for you, because these will happen up front and you'll have to pay that. And I think as employers, we don't do a good enough job of being very clear and saying it like it is for these types of plans. There's a couple of things that we have to also think about with the cards themselves. There's two issues. One of those issues is the discrimination legislation that's out there. Your PBM knows when a copay card is being used, and if you're allowing those cards to be used, you're allowing those who have a card to profit from them. But what's not happening is all of the rest of the people out there utilizing those drugs are not being told that there's an opportunity like this for them. And in fact, that could be challenged in itself because you are the sponsor of the plan. The question can be asked, do you have a responsibility to make sure that every person is treated the same? And that is how the legislation is written. It needs to be, whatever is done needs to apply to all like individuals. And that means all people taking the drug. And how are we as employers making sure that this is happening? The reality of it is we're really not, unless you've instructed the PBM to contact every single person about the opportunity of a card. So discriminatory action could be a claim against you as the sponsor of the plan. The other piece of the discrimination piece is what was mentioned before. There are other people with high medical costs who don't get a waiver of the deductible, because waiver is in fact what is happening when those cards are being used. You as an employer have a system in place that allows that employee to receive a waiver of a portion of their deductible. Yet if you take, for example, say someone that needs an insulin pump or someone that needs a prosthesis to be able to walk or to eat, they don't get that same waiver. And again, you're talking about, are we treating like individuals the same? The other part of it is the fiduciary responsibility of the plan, which as a plan sponsor with a self-insured plan, you do have the fiduciary responsibility to protect the interest of the plan. And when we look at deductibles and out-of-pocket max, they are part of the employee cost share contribution, meaning you have said, okay, we need to maintain our budget at this amount of money for health care benefits this year. Part of that needs to be company-sponsored. Part of that needs to be employee-sponsored. And the way that you have employee sponsoring is by having the premiums, deductibles, and copays and out-of-pocket max. So with that, again, you have a fiduciary responsibility to maintain what you have done to protect the interests of the plan, and that is calculation of an employer and employee cost share. Yet you're allowing some employees to not give the contribution that because of their usage of medical or prescription drug services, they should be contributing to the plan, and therefore you're not protecting the interest of the plan, and that could also be challenged. So when we're looking at the legalities of things, there are issues that can be raised, and if you've got a savvy employee, which, you know, my history with P&G, they were all about being savvy about things, they can, you know, bring that forward. So, you know, what do we do? And what I basically, you know, tell employers is, first of all, if you have just a PPO plan, maybe you should consider having a separate deductible and prescription drug deductible, separate medical and separate prescription drug, and make that prescription drug lower than the medical deductible, because typically your prescription drug costs are lower unless it's a specialty drug, and by them being compliant to their drug medication therapy, you're actually helping the plan by doing that. So, you know, that's a thought there. The other thing that when we were talking about hemophilia, you can develop a rider to your plan. You could, for example, in the case of hemophilia, say, we are going to change the employee cost share for individuals with hemophilia because it is a life-threatening situation. There are no other alternatives available, and therefore we're going to cover the medication at this amount, and that is actually written into the plan as a rider. The only drawback with that is you're treating all like individuals the same because you're applying this to all individuals with hemophilia. However, that rider is in place now and forever until another amendment is written, and then you have to be sure that no one is missed on that particular coverage level, and that in itself puts a lot of backroom information in there. So, you know, for me, it's a matter of, one, we need to educate employees better. We need to not design counterintuitive measures into our plan, like, you know, not allowing the outpatient infusions, which should be happening, and that's totally counterintuitive. And then I think the other answer here is we need to have legislative change concerning HSAs. And the only way that is going to happen is if the coalitions and the employers rally together to lobby for a change in the laws around the HSA so that the people aren't hit with the high deductible when they have those kinds of medication costs. That in itself, putting in an HSA for someone that has a chronic health condition where they need to take a medication on a daily basis, is totally counterintuitive to what you're trying to achieve with the plan. So when I advise people, you know, I first of all say don't put in a full replacement. There needs to be an option for people that do have serious medical conditions where they are going to pay a higher premium, but they're also going to get, you know, that first level service when they need it. And, you know, two, make sure that if you're putting in a high deductible plan with an HSA, that you certainly are making sure, absolutely sure, even if it comes down to contacting every individual that enrolls in the plan during your annual enrollment period, do you understand that by enrolling in this plan that you are going to have to pay first dollar for every single service, including prescription drugs, before the plan takes effect? And we're just really, as employers, not doing a good enough job of helping people to understand that.
Thank you, Sandra. Sorry, I was stepping on someone. Thank you, Sandra. Really appreciate that insight. You are always so consistent with being fair to all and considering the plan and its fiduciary responsibility. So we are going to go to Lauren now.
So thanks, Denise. I think I'm going to give my 7 minutes back to the webinar. I feel like we have so much more to talk about, and I know Bruce is going to talk about some of the ideas for employers to consider when they're putting HDHPs in place. I think that's a valuable conversation. So in lieu of my 7 minutes, though, what I would encourage is for employers who are in the audience to, please share your thinking. We'd love to hear from you. And then I know Cheryl is moderating that chat box. So with that, I'm going to turn the program back to you, Cheryl.
I'm actually going to have Denise ask the employers a couple questions, and that would include you, and I would ask that you limit your answers to just 30 to 60 seconds, please.
Yep.
Thank you, Cheryl. So you've alluded to this in your speaking, but if you could give some more specific examples on what you recommend an employer should do to help prepare employees for an accumulator program. So effective communications that you've used and anything else that you want to add in. And Andrea, do you want to start with that?
Sure. So on the communication side, what we have, so again, we have not implemented the Copay Accumulator program yet. It's not going to take effect until 1/1/19. But from a communication standpoint, what we've done for our employees is we've sent multiple letters. So we've done 2 rounds of letters that explain the program and what the impact is on them. We've also done at all of our annual enrollment meetings, we have talked at length about this change and what that means to them and what they should consider. So is it more HSA seating, or do you want to move towards from the high deductible health plan to our standard PPO plan? We will be following up I'm looking at with our PBM at doing another follow-up in January of next year to also serve as another reminder around this change. So I'm hoping that we have a better level of understanding, but we will also probably potentially, I'm going to look at just now from this call, look at seeing if our PBMs can do outbound phone calls to those that are going to be impacted to explain it to them as well. So that's what we've done from a communication standpoint. What was the other piece?
That's it. That's good, and okay. I love that we triggered something for you.
Yeah.
Wonderful. Sandra, you want to comment?
Well, I think I covered mine when I was talking earlier. Just again, the education piece and making sure that it's really solid, and employers need to stop bitching about the cost of the drugs and get out and actually do something about the barriers that are being put in place. And, one of the barriers with a high deductible plan with an HSA is the HSA or the deductible applies with prescription drugs as well. And as I said before, that is counterintuitive to what we're trying to achieve. We're trying to get people to be compliant to their medications, and when they have to pay $1,000 a pop or whatever, they're not going to be compliant. They're going to get help for as long as they can through a copay card, and then they're going to be hit. And it will at least be hit to the point of the deductible that is money out of their pocket. And they're going to continue to have the medical cost along with it, but it may be quite a while before they actually meet their out-of-pocket maximum on the plan. So most people don't have that kind of money set aside, and yet they're being forced into high-deductible health plans with HSAs, and they're not prepared for the consequences of having that, whether it be the need for a specialty drug or whether it be, appendicitis that they did not expect to have happen to them. They're being hurt by this particular type of plan design, and we need to find ways to counteract that.
Thank you. So to kind of come off of that, Sandra, in terms of employers need to stop bitching and take action, Lauren, I'll ask you if you would respond to what changes do you think need to happen in the industry to make expensive specialty and biologic drugs more affordable for the member, and what, if any, role does the employer have in helping that to happen?
Well, I thought I was going to get the easy communications question. Okay. That's a big.
You go back to that if you'd like.
No. I like this question. This is a webinar in and of itself, and I know we're behind time. So let me just say what employers can do. Number one, engage with your local coalition and others in the country who are working on this project. The answer is not single. There are drugs in your small molecule formulary that should not be there. Please read the report coming out, and please look at the work that Cheryl has done in the PBM business model to understand how you can impact that. 2, specialty drugs. There are opportunities around biosimilars. Hop on that. There are policy fixes that must be made to our patent system, which is being abused. And it is really necessary, so those are policy changes, and there are others. Work with, support coalitions who are working on that on your behalf. 2, though, there are market pushes for uptake of biosimilars. There are biosimilars in the marketplace right now that are not being used that would save you all 20 to 30% on your drug spend. Talk to your health plans. Ask them why, how many, ask them first of all for education about biosimilars, and again, come to your coalition to help you with this as well, and ask them what the opportunity is within your direct spend, and ask them why they're not pushing it, why they're not paying doctors differently, why they're not promoting, biosimilars. Move to the answer, and I'll sum it up with this, the answer to fixing this problem is to engage in value-based contracting such that you are working with a care system that has accountability for the total cost of drugs. Because until we give physicians the information and the incentive to prescribe the right drug, to use Andrea's term, the right drug that people really need, we want them to be on that drug for a lot of reasons. But we need the physicians to be prescribing the right drug, and that means considering not only clinical excellence, but value excellence. And if physicians have the information and the incentive to do that, they will be the best agents ever. So support efforts in your community, and again, talk with coalitions around this. There are experts who are working on this, to create value-based contracting with care systems where there is an incentive to look out for your financial well-being and the financial well-being of your employees by making sure the right drugs get prescribed, by making sure the physicians have the information they need at point of care. I'll stop there, but there are many, many, many other solutions. I look forward to another webinar to talk about all of them.
Thank you, Lauren. So we're going to turn this back over to Cheryl now.
Thank you, Denise, and all of you. Very helpful recommendations. A lot of times webinars are 60 or 90 minutes, and I insisted that this one was longer, and it's still not enough. So expect to hear more from us on this in the future, including a report summarizing some of what we learned today and better understanding both sides and what can be done. I want to ask Bruce to come back and share. He's got a couple slides here that provide some guidance, and then I'll come back to the table. And if you submitted a question and we didn't answer it, I am going to submit that question to the speakers. I'll ask for their feedback, and we will share it in an FAQ or a document with the group. So because we ran out of time, I don't want to go into that. I want Bruce to have a chance to go through these last few slides and then me wrap it up. Bruce, are you there?
I am here.
Thanks, Bruce. Go ahead.
Great. So what we have on the next on this and the next slide are some sort of structured approaches to considering potential solutions for this. And you'll note that they're in different buckets and I think with varying degrees of proactive, reactive, upstream, downstream nature. Some of these I think we can skip over because we've already discussed them. I think one of the key questions under the HDHP options is bullet number 3 about the financial means testing. On a review of plan selection tools that are commercially available, we found none that incorporate an individual's income and ability to pay an unanticipated amount as part of the plan evaluation process. So earlier, my colleagues have spoken to this issue. Should individuals who are in low-wage worker jobs be in an HSA where they may risk facing a $2,000 plus deductible payment? And if people do choose the HSA despite that, they should be counseled so that they fully understand, since we know that that is a major concern. Wage-based benefit subsidies, we're seeing growth of this in the marketplace. I'm still not sure that we're seeing this done in a thoughtful way. A lot of employers are doing premium discounts. I would submit that that's not the answer because low-wage workers are still faced with high deductible amounts and still running into the same problem. One solution to that is providing low-wage workers so-called gap plans or supplemental plans that can help them by supplementing their deductible amount if provided on a means-tested basis, given that those are lower-income individuals. With respect to HSA funding, company contributions can be front-loaded. Communications can further support employee contributions. There are a couple of companies out there that will provide effectively loans against HSAs that employers can contract with. And if anyone wants more information on those, more than happy to provide. And the other thing, which I think is probably more impactful, is wage-based HSA contributions. That affords benefits to employers on a few fronts. It reduces tax burden, if I understand correctly. It also puts money in the hands of employees who are going to, who are the ones that are going to use their healthcare dollars rather than subsidizing through premium reductions, rather than subsidizing all individuals who are low-wage earners, because we find that a significant portion of them are young and don't even access their healthcare plan. So why subsidize people if they're not even going to use their plan? Third column, medication subject to the deductible. This, to me, based on our research, looks to be a substantial and meaningful way of impacting individuals' exposure to or ability to access medications for which there is clear benefit. The important point to make here is if people have gone through a prior auth or step-edit process, have tried medications and failed, and this is where they are, the specialty drug provides them benefit, those are the drugs that, from my perspective, need to be or bear consideration for being put on the preventive drug list. And again, from what we saw, pennies or penny on a PMPM basis. Next slide. So if we talk about value-based insurance design, some of these are probably administratively going to be challenging, but I've seen some hint that this may be forthcoming, and that is for individuals who have been compliant and have failed all less costly therapies, why not give them a lower out-of-pocket cost since they have been compliant and failed a step therapy approach? Another is, and I think others alluded to this, establish a specific tier for preferred specialty drugs where those less expensive treatment options don't exist, or limit the copay accumulator adjustment program only to those medication classes where less expensive treatment options don't exist. And then lastly, for specialty RX users, and I have another key point to make here, is this notion of means-based financial support administratively may be challenging to track that data. If you've got an employee who is working part-time because they have an incredibly wealthy spouse and that employee is benefits, let's say that employee is benefits eligible, do we really need to be subsidizing them? There are sources of subsidy, but I think the big challenge is how do we accurately capture our understanding of means-based level of support. The last point I'll make on this particular column is we were told in the course of performing this research project that patients were offered the opportunity to pay the pharmacy on an installment plan, and that they were also directed to resources to provide needs-based assistance to secure their medications, yet we still saw a 30% absolute discontinuation rate. So current processes, even though with all due respect to the PBM, even though they say they are working, the practical operational answer is they don't appear to be. We've asked for a more specific accounting of that, and it's a bit concerning to me that maybe there's a bigger issue here that we also need to deal with. I've included this other considerations column just to note that there may be other ideas that we haven't even thought about, and I think we've heard a few of those during the call today, and would certainly encourage all of us to think about other potential solutions. Clearly, one that's not listed here is let's get rid of the drugs that aren't providing value. But there's certainly more, and I think the more we think and talk about this, the more opportunities we'll find for creative solutions to the problem.
Thank you so much, Bruce. First of all, I want to thank all of you very much for being on today's call. It was not enough time, it never is. I want to especially thank our speakers who shared their stories. We are not going to stop discussing what's going on in this space because we know a lot of our members are using or thinking about using accumulator programs, and we want to address the issues of noncompliance, non-adherence, not getting needed care. So I encourage you, you will be sent a copy of the slides along with an evaluation form. If you have questions, if you have comments, and if you have ideas, we ask that you please complete that form, even if you don't complete the form, but especially of those other three, because we will be continuing to take the knowledge and information that we're getting and share it not only with our members, but with our sister coalitions members. More to come on this. Thank you for supporting MBGH and coalitions in the country today. Employers are the real purchasers of healthcare, the real payers of healthcare. And just a quick plug for the National Employer Initiative on Specialty Drugs. You'll see the link to the online employer toolkit, which is available to any employer or stakeholder in the country to better understand what is going on in this space. We have intentionally avoided putting too much information about the accumulator programs because we wanted to hear about today's program and provide that fair and balanced presentation. I know that the speakers, especially the stakeholder speakers that were on the call today, will continue to work with us to try and solve some of these issues on both sides. Happy holidays, everyone, and thank you again for participating. Good day.